slide show it here? Yes. But not full screen. Sorry, I cannot read. Which one is full screen? Yeah. Great. Okay. Oh, great. Thank you. Okay. What's the true benefit of intracorporeal anastomosis? Many articles have talked about these topics, and all of them summarize that the advantages of intracorporeal anastomosis include less potential of malalignment of the bowel limbs, especially when we bring the bowel out of the abdomen. It's sometimes not easy to find the real alignment. Sometimes malrotation might happen. And also has the advantages of less mesenteric edema or trauma during the extraction. And it also allows extraction through natural orifice, or can make a suprapubic incision. The suprapubic incision has the advantages of cosmetic advantages, and also have less potential of initial incisional hernia. But most of all, the patient has less wound pain for the lower suprapubic incision. So the advantages of ICA include fewer conversions to open and fewer post-operative complications and shorter hospital length of stay. However, some surgeons deny to do the ICA because of the obstacles of cost and complications and longer operative times. How to overcome these obstacles? I will show my simple and standard technique. There are several ways of ICA for RjColoMIS2024, such as the intracorporeal alignment, ISO or anti-peristaltic, or the closure of the stomy, either by sutures or by staples. No one is superior to other. Only depends on your decision and depends on how you can do it well. And that's my RjColoMIS2024 pod site. And the two of the photos shows the suprapubic incision, and the right one is a nose, natural orifice specimen extraction. I'm usually a lonely surgeon, work with a scopeman only, no assistant. But now, since I know how to use the rubber and the single traction, I can put an additional port over right upper quadrant of the abdomen for better exposure of the mesocolon and better counter traction. And I prefer stance between the legs, and that will make the application of staple more easily to do the intracorporeal anastomosis, and also to dissect the surgical trunk from bottom to the top. And for my point of view, I think most important tips and tricks is to open the ostomy site as large as possible, but as small as possible. To open a wider stomy can facilitate the insertion of a staple, but keep it smaller, and then we can simply close the stomy by staples. So I prefer to divide the bowel before surgical trunk and use ICG to check the blood supply. And I cut at the anti-mesenteric site. So if I divide the bowel properly, I can simply open the stomy. And this ostomy opening should be large enough to insert the staple. And this is anti-mesenteric, anti-peristaltic. And I grasp the staple to make sure all the defect was closed. So it's a very simple technique and very fast. The only disadvantages are the cost of staple. It usually takes 4 staples. And sometimes we encounter the failure of the anastomosis. When I checked the ICG, I found a part of the distal end is now well blood supplied. But initially I refused to take the result. So I keep on exam of the bowel. Is it a real poor perfusion? And I see the vessel, I think, okay, it's good. I don't have to cut more. So I keep on doing the anastomosis. And I find the blood supply is well shown by ICG, fluorescent scope. What we will do? Keep on doing or resect more? And the second mistake is I choose the wrong side. I cut at the mesenteric site. Although it looked like the anti-mesenteric site, but misidentified as the anti-mesenteric site. Although it looks quite similar. But I found the formation is quite different from the usual one. So I check ICG again. You can see there is a defect near the staple line. So what we'll do? Open the bowel, open the abdomen, bring the bowel out to redo the anastomosis. I'm still struggling. Cut it or not? It looks like there are some blood perfusion, but I'm not sure. So I decided to cut again. So I divide the mesentery to the estimated transition site and make 2 ostomy. It's like an open procedure when you brought the bowel out of the abdomen. And I directly close the defect by just like the open procedure. And the patient recovered very well without any complication. So anytime when you feel uncomfortable about the anastomosis, you can recreate as long as you understand the procedure of the intracorporeal anastomosis. And we always do intracorporeal anastomosis for our colon cancer, for right colectomy and for left colectomy. But As I know, most of the surgeons prefer extracorporeal anastomosis for left colectomy. And maybe several ways of bowel reconstruction, either by the staples, or by the circular staples, or by the linear staples. And most of us may just broaden out and do the right side. And there will be an anti-mesenteric and anti-peristaltic anastomosis. However, either by anti or iso, you need an extra length of bowel, and that will make the bowel has higher tension, because sometimes we encounter enough remained bowel length to create the anastomosis. So several approaches of end-to-end anastomosis have been introduced, such as Jun Watanabe sensei introduced his technique. Is a delta-shape end-to-end anastomosis, and also sutureless. Or another surgeon introduced also a total stapled anastomosis, create the bowel. For me, I have tried several techniques, and I prefer this one. But it takes time. This method is just like a hand-sewn anastomosis, and we can do it easily by robotic, but it takes time. Therefore, recently I used this type, and it's less time-consuming. And I create the posterior wall by staple, and suture the anterior wall. By this method, I can make sure the diameter of the bowel is good enough, because I suture the anterior wall. If I do the total staple technique, sometimes the bowel wall may be restricted. So I approximate both ends of the bowel and open the bowel at the both ends. And I use a staple to create the posterior wall. And the stage suture assists me to close all the defects. And then I use a 4-0 PDS to do a corneal suture over the anterior wall. It's just like open method. And all the mucosa edge is inverted into the lumen. It's not easy for the beginners, because we can only see the tension. We cannot feel the tension of the suture material. So in the beginning, I always broken the string. Then I do the second layer reinforcement, seromuscular sutures. And then I put the colonoscope to check the anastomosis tight and intact, and most of all, the diameter is good enough without stenosis. So this is my preferred way of ICA for left hemicolectomy. And with ICA, we can also offer the nose procedure for the patient. For a sigmoid colon or upper or middle rectal cancer, we extract the specimen through rectum. For left colectomy or right colectomy, we extract the bowel through colonoscope. We do not use rectum routinely to extract the specimen because maybe I am old-fashioned. So I divide the proximal side, and after the scope is inserted through the anus, I cut the distal limb. And using a snail, I can hold the specimen. This procedure is only preserved for early cancer. And for low BMI, if the mesentery is bulky or the tumor is bulky, it's not impossible to extract through the scope. The end of the bowel might be edematous or traumatized, so I resect the edge, and then I do the end-to-end anastomosis. This is also an intracorporeal anastomosis. We do the end-to-end anastomosis intracorporeally. The specimen is extracted through the rectum. And double stapling, double purse string suturing over both ends. And there will be a simple end-to-end anastomosis. So that's my way of ICA, and welcome to our conference in this November. And this is my team. Thank you.
Thank you,